Hello and welcome to my channel. This is Pritesh Jadhav and today we shall be dealing with a very frequent symptom known as dizziness, more frequently called as vertigo in clinic. So let's get started with how to approach a patient of this. The term dizziness is used by patients to describe a variety of headache sensations or gait unsteadiness, with a careful history distinguishing between faintness, that is a pre-syncope, and a vertigo, that is an illusionary or hallucinatory movement of the body to the environment, that is often described as by the patient as a feeling of spinning, is usually possible. When the meaning of dizziness is uncertain, provocative tests to reproduce the symptoms can be helpful. Some of these tests include the Valsalva maneuver, that is the increasing artificially the intrathoracic and intra-abdominal pressure, hyperventilation or postural changes leading to orthostasis, which may reproduce faintness. Rapid rotation in a swivel chair is often a provocative test for reproducing vertigo from an auditory or ear cause. Benign positional vertigo is identified by the Dix-Hallpike maneuver to elicit vertigo and a characteristic nystagmus. The patient is sitting in a sitting position with the head turned 45 degrees. Holding the back of the head, the examiner gently lowers the patient to a supine position with the head extended and backwards to 20 degrees and observes for nystagmus. After 30 seconds, the patient is turned back to the sit-in position, and after 1 minute of rest, the maneuver is repeated on the other side. If a central cause of vertigo is suspected, that is, from the signs of peripheral vertigo being absent or a neurological abnormality is present, then a prompt evaluation of the central pathology is required, and such patients should be treated more appropriately than the peripheral causes of vertigo or dizziness. The initial test is usually an MRI scan of the posterior cranial fossa of the brain. Distinguishing between the central and peripheral etiologies can be accomplished with vestibular function tests, including video nystagmography and simple bedside examinations that include head impulse test, that is a rapid, small amplitude head rotations while the patient is instructed to fixate onto the examiner's eyes. If a peripheral vertigo is suspected, a catch-up saccade is seen at the end of the rotation, and a dynamic visual acuity, that is the measurement of the acuity at rest with the head rotated back and forth by the examiner. A drop in acuity of more than one line on a near card or a Snellen's chart indicates a vestibular dysfunction. Now let's look at how to treat a brief overview of how to treat a patient of vertigo. Treatment of acute vertigo consists of vestibular suppressant drugs for short-term relief. They may hinder the central compensation, prolonging the duration of symptoms, and therefore should be used sparingly. If you found this vestibular rehabilitation promotes the central adaptation processes and may habituate the motion sensitivity and other symptoms of psychosomatic dizziness. BPV, that is a benign positional and paroxysmal vertigo, may respond dramatically to repositioning exercises like the Hals-Dix maneuver, like the Epsley and the Epley's procedure designed to empty the particulate debris from the posterior semicircular canal. You can watch videos of this on YouTube. The vestibular neuritis, the antiviral medications are of no proven benefit unless herpes zoster oticus is suspected. Some data suggest that glucocorticoids improve the likeliness of recovery from a vestibular neuritis. Meniere's disease may respond to a low salt diet, that is a diet less than 1 gram per day, or to a diuretic. ENT referral is often recommended to these patients. Recurrent episodes of migraine-associated vertigo should be treated with an anti-migraine therapy. If you found this video on vertigo to be helpful and informative, please consider liking and subscribing to this channel to bring more such videos to you. Thank you very much.